welcome to our panel of expert oncologists and surgeons in breast oncology. We're here at the 2018 San Antonio Breast Cancer Meeting in San Antonio, Texas, and we're going to talk as a group about triple-negative breast cancer, the challenges in treatment, and some of the new directions that are really exciting that we've heard about in 2018, and how we're going to apply those to practice, as well as the challenges for the future. And then we'll wrap up with some of the exciting developments over the last year and how we're going to apply those to our clinical practices. I have here with me today Giuseppe Sorigliano, who's from the University of Milano, Beth Mittendorf, who's from Dana-Farber Cancer Institute. I'm Hope Rugo from the University of California, San Francisco. I have Rebecca Dent from the National Cancer Center in Singapore, Rita Nanda from the University of Chicago, and Aditya Bardia from Massachusetts General Hospital. Thanks very much, everyone, for joining me today, and I think we're going to have a great conversation. So we're going to start and talk about latest unmet needs in triple-negative breast cancer, of which there are many. Giuseppe, tell us a little bit about what you see as the unmet needs coming to the end of this year.
So the first of the unmet needs, I believe, is recognizing breast cancer not as one single disease, but as several diseases. If we look at the molecular classification of breast cancer, of triple-negative breast cancer, we know very well that we have the basal-like or BRCA mutated. Then we have the luminal androgen receptor-like, the immunomodulatory-like, and finally the mesenchymal-like. So it's quite important to recognize that response to treatment for any one of these subtypes is completely different. And I also believe the outcome is different. So we have several questions, and the first one is which is the ideal neoadjuvant treatment? Should we use cisplatin for all subtypes or for specific subtypes? In case of residual disease, should we consider capecitabine as the optimal treatment for extended adjuvant treatment? And then what's about the metastatic setting? Should we treat all the metastatic patients with a standard of care, including anthracycline, taxanes, or a combination of paclitaxel and atezolizumab? And if we use immunotherapy, should we select just PD-L1 positive patients or other subpopulation? And finally, also the surgical management, I believe, is a key issue, and specifically following the introduction of the PARP inhibitor in the standard of care in the BRCA mutated, my question also is, should we perform a skin-sparing mastectomy to patients with BRCA mutation, or should we do a total mastectomy? Several questions are still open, and I believe in the next months we will have many answers to these questions.
And panel, I mean, what do you think in response to those unmet needs? How do you see us addressing the question of the subsets in triple-negative disease? Is this something we're going to be incorporating? Are we going to be doing additional intrinsic subtyping or other subtypes like the Vanderbilt-Peyton-Pohl type typing?
You know, I get that question all the time from patients. What subtype of triple-negative breast cancer do I have? And I think at this point, it's a great research tool to try to identify the different subtypes and identify novel targets for therapy, but I don't think we're quite ready for prime time yet. I think eventually we want to get to that point where we can do some sort of an assay and expression profile and say, you have this type of cancer and we know that this type of therapy is the best therapy for you. But in 2018, we're not there yet, but I'm hoping that we will get there. So I don't generally do that type of testing outside of a clinical trial at this point in my practice.
So I think you say we're not there yet because we don't necessarily have effective therapeutics for each of what we anticipate will be the subtypes. But to your point, if we are able to identify the Achilles heel of an individual patient's tumor and we can target it, we potentially could tailor and arguably what they say now, the de-escalate therapy. And I'm thinking of a presentation at ASCO this year where patients who had BRCA mutant triple-negative breast cancer and received just talazoparib in the preoperative setting, and they actually saw complete responses. So I think, as you're suggesting, that we're moving that direction, and when we get the effective therapies, we probably will be able to realize that, what you're suggesting is telling each patient, you don't just have triple negative breast cancer, you have this.
It is really interesting because you could classify these cancers. Of course, we classify them by receptor status first, but you classify them by mutations, germline and somatic, or these sort of expression profiles. And it is interesting to try and figure out how those are all going to fit together moving forward.
So I think the molecular classification was important for us to recognize that triple negative isn't just one disease. And so there was a recent review in the Journal of Oncology Clinical Practice that highlighted these clinical relevant subgroups in 2018. And I think it's more about the pathways that are upregulated or aberrant that's going to lead us in the right direction. And I think what you're seeing is the clinical trials are reflecting that. So my hope is in the next 1 or 2 years, and we're already starting to see, such as PARP inhibitors, that there are different groups that we can already target, but I think it's going to be actually pathways that we're looking at, maybe not just one single biomarker or mutation.
I think it's about being actionable. The reason we are using the triple negative classification is because ER is actionable and HER2 is actionable. So once we have something actionable against the molecular subtypes, I think we would be using it. If the actionable is for genotyping-based therapy or pathway-based therapy, we would be using that. So ultimately, it will be the clinical utility of the test that would guide what we use.
We have at least 2 actionable subtypes. First one is the basal-like or BRCA mutated. It's a clear evidence that they respond better to PARP inhibitors or platinum salts. And maybe the immune subtype, since we have evidence that a subgroup PD-L1 positive may derive benefit from a combination of chemotherapy and anti-PD-L1. And we have some proof of concept, at least in the luminal androgen receptor-like, using anti-AR. So we are moving forward in that direction, I believe. Maybe not soon, but in the future, I believe we will tailor treatment according to subtypes. One
of our challenges is that we don't really know if the tumor we get from metastatic tumor samples represents the entire tumor in the patient. When we all see these discordant situations, we see ER positive tumors that lose ER but still behave like they're ER positive in their growth patterns. So there's a lot of heterogeneity. Do you see that the blood testing is really going to move forward and take over doing biopsies in the metastatic setting, and then that will help us understand how to treat early stage cancer? I know at Mass General you're doing a lot of blood testing routinely.
I think the blood testing at this time is really helpful for looking at the genotyping profile of the cancer. So circulating tumor DNA and looking at mutations, be it PIK3CA, ESR1, BRCA, germline, somatic, I think that's where it's being used and potentially is actionable. I'm not sure we would be able to look at the RNA profile, so the molecular subtype, based on blood. Potentially one could do it by looking at circulating tumor cells, but I don't think so we are there yet.
Do you see, Beth, that this cell-free DNA, which has now got 5 different names for it, but mostly with the end of DNA, but the first 2 letters are different, but plasma, et cetera, tumor specific, but that might be a way in the early stage setting to really determine what the right treatments are for these patients. There's been a huge amount of interest at this meeting, actually, using cell-free DNA as a way to monitor risk of recurrence.
Sure. I think, as was alluded to, this is a developing technology, and there's so much interest in cell-free circulating tumor cell DNA that we will get there. With respect to the early stage setting, I think there is a potential opportunity with neoadjuvant approaches to use it to assess response so that if a therapy is not going to work, we stop it or change early. With respect to the adjuvant setting, I think we're all going to be quite interested in looking for markers that predict who are the highest risk folks so that we can have conversations about an extended adjuvant therapy. And then clearly there will be a role in the metastatic setting.
At the moment, though, it seems as though certainly use of cell-free DNA and looking at intrinsic subtypes doesn't really help us much in clinical practice, although it does seem that mutational screening is very useful. Do you generally get some mutational screen on your patients with advanced disease? Do you ever do it in early stage cancer?
So I think for a lot of the trials that are ongoing, especially looking at, as you said, looking at the PIK3CA AKT, so the gain of function mutations appear to be quite stable and reliable. So the concordance rate between the plasma testing and the tissue looks quite reliable. and consistent. Also, what's interesting is they appear to be over time very similar in the primary and metastatic, which is not the same for the entire spectrum. So for recruitment for clinical trials, I think it's really exciting that we'll be able to do this mutational analysis a lot more efficiently and easier for the patients. So I think that's where I think it's really exciting. And I think so far, I think monitoring of disease also looks very promising. We're just not there yet in clinical practice, but I think we all should be sort of following the trials.
So if you have a patient who has metastatic disease and they had their tumor sent either at initial recurrence or from an adjuvant sample for NGS, say tumor sample sent, and they say to you, should I rebiopsy my tumor now? I've had 2 therapies. What do you tell them? Do you rebiopsy serially to look at additional mutations?
If there is a refractory disease to the standard of care, usually a rebiopsy, and I perform a multigenomic testing. It's quite rare to find an actionable mutation, but if you have a phase 1 unit in your hospital and there is the opportunity to enter a clinical trial, it's an opportunity for the patient, I believe. So my advice should be to rebiopsy.
And would you repeat NGS testing serially?
Just in case the patient is receiving a targeted agent and is progressing to this targeted agents, because maybe there is a new driver mutation and you can explain also why it's progressing to a specific actionable pathway, anti-cancer treatment.
Do you do that also?
We're moving more towards liquid biopsies, but the concept is the same as you were saying. With tumor evolution, you can have acquisition of new alterations. The ESR1 story is very telling, where it was not discovered in the primary specimen, but when the metastatic specimens were sequenced, that's where ESR1 mutations were discovered. Even HER2 mutations, it appears that a subset of HER2 mutations are acquired. So if you just sequence the primary tumor, you would miss them, and that's very actionable.
I think the other thing is, under the selective pressure of treatments, I think we've really underestimated how one treatment impacts subsequent treatments. I think the key thing, though, is outside of clinical trials, I think this isn't something that should routinely be happening unless you have, a trial-directed approach where you can put these patients on study where it's going to change your management. And I think the other thing is that, you've got a patient, and as you were saying, if they're not behaving as you clinically anticipate, that's another good reason to potentially biopsy. When you have discordant results to a treatment, you've got a liver disease that's progressing, lung that's responding, that's another sort of indication that there's something unusual going on.
So it's actually fascinating. I mean, we're really seeing a big change. I think the ability to test blood, of course, has really expanded our abilities to look at serial changes over time. But how to apply this in clinical practice is still a challenge. We've made some real advances in the treatment of triple-negative breast cancer this year. We clearly still have a long way to go. But the biggest splash, of course, this year really has been immunotherapy. Everybody's talking about it everywhere. All the papers, our patients, they have all wanted, even if they don't have triple-negative breast cancer. Rita, tell us a little bit about what we heard this year.
Yeah, so it's been a really exciting year for immunotherapy for triple-negative breast cancer and just triple-negative breast cancer in general, with some new therapies that are going to be approved. Obviously, the Impassion 130 trial was really exciting for those of us who've been trying to develop immunotherapy drugs for advanced triple-negative breast cancer. It's been a really exciting year. So the Impassion trial, I think, as you know, demonstrated that adding the anti-PD-L1 therapy, atezolizumab, to nab-paclitaxel chemotherapy significantly improves progression-free survival with a trend to overall survival in the overall population. But I think what was most remarkable about the Impassion 130 data was the PD-L1 positive population. That is the population that really seemed to derive the benefit from the addition of atezolizumab to nab-paclitaxel, with not significant yet, but immature data set of a 10-month improvement in overall survival. So pretty exciting. A modest improvement in progression-free survival, but a pretty substantial improvement in overall survival. So it'll be really interesting to watch these data as they mature. This was the first presentation, but I think a very hopeful time for women with triple-negative breast cancer that's PD-L1 positive, and that's about 40% of triple-negative breast cancer. So
It is really exciting data, I think, just to see something in breast cancer, since we've seen successes in so many other diseases, and prove that it's not all immunologically cold. But there's been a lot of controversy, and certainly discussed here, about the biomarker PD-L1 and the fact that there seem to be many ways to call the biomarker.
Right.
Beth, how do you see that evolving?
Yeah, I think that's an outstanding question, because I believe we anticipate that there will be an approval for the combination of atezolizumab and nab-paclitaxel in first-line metastatic triple-negative breast cancer, and it'll be for PD-L1 positive tumors. And I just said PD-L1 positive tumors, but when you look at the Impassion 130 and the strategy with the atezolizumab development, they're actually looking at PD-L1 expression on the immune cells, and they're using a very specific antibody. So I guess my question to all of you, and it's a question we have at our own institution, how are we going to be testing for PD-L1? Are we only going to be using the antibody that was used in the Impassion 130 trial? Our colleagues in lung cancer and other tumor types have different antibodies they use to test for PD-L1. They're looking at PD-L1 on the tumor, not the immune cells. And there's actually some nice data from the Yale group where they've looked at the 5 different antibodies used in clinical trials, and there's differences in sensitivities. There's differences in pathology intra-observer consistency with respect to identifying PD-L1 on the tumor versus immune cells. So this is something that I think we're going to, as it kind of rolls out, we're going to just, I'm certain that many institutions will have specific strategies. I've already started seeing patients referred to me who have PD-L1 testing from an outside institution that doesn't even specify which antibody was used. So it's something that's going to be, an interesting kind of year to see how we in the breast cancer field incorporate that biomarker, because, I mean, Rita could probably speak to additional trials we anticipate will read out, which have used a different biomarker strategy.
Yeah, no, I mean, we're expecting probably Keynote 355 with pembrolizumab to read out next year, and they've used a different antibody and a different compartment that they're looking at. They're looking at both tumor cells and infiltrating immune cells as opposed to just infiltrating immune cells. So it's just going to be all over the map, I think, for a while.
And consider that in the Impatient 130, 60% of the patients have been tested on the primary. So should we test since the beginning our patients for PD-L1?
So just to clarify that these in the Impassion 130 trial, just because of the difficulties of these phase 3 registration trials, a lot of the tumor, somewhere close to about half of the tumors, were actually obtained from the early stage diagnosis as opposed to metastatic.
I think that's a real issue because, as we all know, the immunologic aspects of the tumor microenvironment can change significantly over time. And PD-L1 in particular is a fairly dynamic biomarker. As soon as you have an immune response to the tumor, those T cells that rush in are going to release interferon gamma, which is going to cause PD-L1 expression to go up. So the question does really become, did that reflect the current PD-L1 status of the tumor? And Rita and I were actually discussing this yesterday evening. The Keynote trial will give us a little bit more information because the requirement was for a biopsy closer to the time of initiation of therapy. But it's a really good point and something that I think we're also going to need to continue to consider as we think about who we're going to be giving atezolizumab and Abraxane to. I told you I think the indication will be for the PD-L1 positive, but we don't actually know that all of those patients were PD-L1 positive at the time that treatment started.
There are a number of additional metastatic trials. I know we've been talking about Keynote. Do you maybe describe I think there's 2 metastatic trials we're really looking for.
So I think the way I look at it is this is the first trial that gives us an indication that there's a signal in triple negative, at least to begin with. And so I think this is just the tip of the iceberg, and hopefully further studies will help identify which of the patients that truly benefit. We know that PD-L1 expression can vary across also, tumor sites as well, and TIL expression as well. As you mentioned, there's the Keynote 355, which is looking at different chemotherapy backbones, such as platinums and paclitaxel and Abraxane. There's also the 131, which is looking at paclitaxel plus or minus atezo, as well as the early relapsing, so relapsing within the first 12 months. So I think there's a lot, and hopefully the body of literature we can put together, identify better biomarkers to identify those patients. But I think it's so hard for people, out there practicing, because the other thing is we took a long time, and we're still working on HER2 and ER testing, and we know that the PD-L1, the half-life of it is actually only a few hours. So how do we fix the tissue? How's it getting tested? Probably varies considerably. And I agree with you, even in our own institution, you ask our lung cancer colleagues, well, which assay, do you know which one you're using? And I think so there's a lot to be learned, and I think we have to all work together to sort of harmonize and optimize those antibodies. My gut instinct is that as we're seeing in melanoma and lung, that it's actually not just PD-L1, it's going to be a composite sort of mutational signature or other things that we're going to be looking at.
Well,
But it's a good
speaking
start.
of that, there's been a lot of controversy about tumor-infiltrating lymphocytes, and lots of publications about it. Really fabulous work by many of our colleagues. But we had a whole half of a poster discussion session at this meeting where there is clearly huge variations in the way people look at TILs and define them. Do you see a detailed role for TILs in determining the effectiveness of immune checkpoint therapy?
I think you'll probably have a composite score which would factor in TILs, which would factor in PD-1, maybe mutation burden. So with PD-1, you're looking at the immune microenvironment. With mutation burden, what's happening in the tumor, and then TILs in terms of immune response. And there might be other things as well. But I just feel that we'll probably have a composite immune score that'll predict response to checkpoint inhibitor better than just one component.
So the evidence that we have, at least in retrospective analysis from the metastatic setting, is that high TILs may predict a better response to monotherapy to immunocheckpoint. Until now, I can tell you that TILs are prognostic, for sure, in triple negative and they're 2 positive. I am not sure I would de-escalate if I would have a TILs positive triple negative breast cancer, but this is another open question. And we should incorporate also TILs assessment when we stratify in immunocheckpoint trials, much more in the primary rather than in the metastatic setting, because we know that in metastasis you have low TILs. Since it's a metastasis, there is an immunoediting, and so much more refractory to be recognized by the immune system.
That is a fascinating thing we've learned, actually, just over the last bit of time, that somehow there's some down-regulation of the host immune response to the tumor as the tumor becomes more bizarre and more resistant.
Well, the tumors are very smart. They don't want to be detected by the immune system, and so
It's their escape mechanism.
their escape. I mean, so there's any number of mechanisms by which the tumors become invisible to the immune system. One of the ones that's fairly well described is downregulation of the MHC molecule. So antigens aren't even being presented on the tumor cells, so they're effectively invisible to T cells. So I actually think that's going to be a really interesting challenge as we think about taking immunotherapy successes from the metastatic setting to earlier stage disease.
We've seen, so it's a good lead-in, because I think, we believe the tumor may respond better earlier. We've seen that data in the metastatic setting. And then we saw very encouraging initial data from the neoadjuvant I-SPY study that Rita presented. And you actually are leading a neoadjuvant trial as well. And I think we're looking for some additional neoadjuvant data in the next year.
Absolutely. So the way drugs have frequently been developed, and you all know this better than I, we see successes in the metastatic setting, and then we move it earlier. The neoadjuvant platform is an outstanding platform to assess response to therapy for the obvious reason that we then are able to see the impact of that therapy on the surgically resected specimen. I'm going to contend, as I've kind of alluded to, that it's a different story with immunotherapy than perhaps with targeted agents. There are a number of ongoing trials. So the trial you alluded to that I have the honor of leading is looking at atezolizumab in combination with adriamycin and then also with a taxane in the neoadjuvant setting. The trial has accrued well. There is a trial that's looking at pembrolizumab in the neoadjuvant setting, and it is anticipated that those trials will read out here in 2019, I believe. But it's a different challenge, and we know this from actually your data. And what I mean by that is we're talking about taking a population of patients that about 50% are going to be chemosensitive and doing really, really well with ACT or standard chemo regimens, and now introducing toxicity. And so your data presented at ASCO a few years ago was notable for the adrenal effects. We had the data presented from the German group at ASCO this year, and they didn't necessarily have as much additive toxicity as one might have thought, and that's obviously good news, but they also didn't have the bump in the PCR that they anticipated. So I think that, as you alluded to, we have more metastatic trials. We're going to have several neoadjuvant trials that read out here.
Yeah, no, and I think you raise a really interesting point in terms of the toxicity, because we're talking about curable
Right.
patients and giving them lifelong toxicities. And so I do think that, we really need to step up our game with the biomarker analyses from these trials to figure out who really needs these therapies, because then you can feel a little bit better about the potential exposure to some of these, sort of lifelong toxicities.
Although I have to say, we still don't know who needs more HER2 positive therapy yet to start out. So.
Just one more point I wanted to add to Beth's comment was we also don't know if PASS-CR is the best surrogate for immunotherapy or immune checkpoint inhibition, because it may be that looking at event-free survival, disease-free survival is a more realistic endpoint, because we know of the ongoing impact of immunotherapy over time. So I think that's the other sort of unknown, is looking at PASS-CR, but then looking long-term at its long-term effect.
And that is something I think that our pharma partners have begun to recognize, and I give credit to the trial evaluating pembrolizumab in the neoadjuvant setting, because it has co-primary endpoints. So there'll be a PCR readout as well as a DFS readout, and that obviously requires a larger number of patients, but it's the information that we actually need.
Yeah, there was a multi-arm trial looking at pembrolizumab just to assess safety in the neoadjuvant setting that we discussed at our poster discussion session. Peter Schmidt was the first author, and the one thing that he mentioned at the poster discussion was that the patients, regardless of their outcome, who got these tiny numbers of patients, 10 in each arm, but who had platinum as well as their taxane and anthracycline and pembrolizumab, that regardless of their PCR, they had a very good outcome in the first year and a half or so, or year of follow-up, which, when we tend to see recurrences. Now, again, this may just be the vagaries of a tiny trial. We have, we've been really excited about immunotherapy and where we're going, but I think a lot of our interest also is how to take patients who have more immunologically cold disease, which is, at least, we don't really know how many of those patients, but based on Impassion 130, maybe 60% who don't respond as well, but also in targeting other factors that may promote resistance and progression of disease. Maybe by targeting those other factors, we'll be able to meet in the middle at some point. I know, Rebecca, you've been working on some trials with AKT inhibitors.
Sure, so I think that's a very exciting sort of one of the clinically relevant subgroups. And I think for the longest time, we've known that triple-negative breast cancer, there's about, anywhere from probably 20 to 40% of patients that are triple-negative have aberrations in the PIK3 AKT mTOR pathway. So looking at gain-of-function mutations in PIK3 AKT, or looking at loss-of-function PTEN. But AKT as a master regulator, as a nodal point, is so important, because all the cells, for proliferation and for cell survival, need to go through this pathway. And so preclinical data really supported the fact that if you have, let's say, mutations in PIK3CA, if you're looking at AKT inhibition and specifically looking at it's synergistic with paclitaxel, so not just additive but synergistic. So there have been 2 small randomized phase 2s that have shown proof of concept of combining AKT inhibition with taxane-based therapy in the first-line A setting of triple-negative. But most notably, it was the biomarker positive patients that showed the most dramatic improvement, about 4 to 5 months improvement in progression-free survival. For me, what was relevant, though, is we often see responses in triple negative, but we can't sustain them. And the duration of response in those biomarker patients was almost a year. And so last year at ASCO, both, again, there were 2 small randomized phase 2s that also show hints of improvements in overall survival, and that may be some immune mechanism, we don't really know, but it may change sort of under selective pressure the natural history of those breast cancers. So there's 1 phase 3 that's ongoing, which is the IPATINITY, which we'll look at it in a phase 3 context, and there's another phase 3 that's going to be opening. So I think many of us are quite keen to look at these biomarker-driven trials and see if the phase 3 can replicate what we saw in the phase 2 setting.
Do you see a role of combining? I mean, certainly PARP inhibitors are a new sort of kid on the block. Now we have 2 approved PARP inhibitors to treat advanced breast cancer. Are we going to combine these with immunotherapy? Where are we going with that?
So I think we specifically know, looking at PARP inhibitors, that they actually increase the PD-L1 expression. So PARP inhibition may sensitize to immunotherapy. We also know, and we've got some phase 2 data looking at the MEDIOLA trial, look at the TOPACIA trial, some really impressive results in terms of looking at duration of response. The question is, can we expand that beyond germline BRCA? There are a lot of different HRD assays. The one so far I think that looks the most promising is the HR detect, that we can look at loss of function mutations. So I think looking at the combination of PARP inhibition and immunotherapy is a really exciting avenue that we'll see. I think we saw data yesterday. We're specifically looking at the maintenance approach. So looking at platinum sensitivity as a biomarker and then looking at PARP inhibition as maintenance or PARP inhibition plus PD-L1 inhibition. It's a difficult concept to sort of do in breast cancer, but certainly our ovarian colleagues looking at the SOLAR-1 data showed unprecedented progression-free survival when you look at it in the maintenance setting. So maybe, like you said, we have two proof of concept phase 3s that have shown that PARP inhibition versus standard of chemotherapy was superior with improved quality of life, but there was no platinum in the control arm. But maybe as a maintenance strategy, that might be where we actually potentially can see optimization of PARP inhibition and maybe immunotherapy.
Can I tie two ideas we've talked about together?
Yeah.
So one of the questions that Hope you asked us at the beginning was whether we're routinely looking at the mutation status in our patients. And so I guess my question to you all as medical oncologists, we now have the Olympiad and BRCA data to suggest the benefit of PARP inhibitors, and we have the Impassion 130. So if you have a metastatic triple-negative breast cancer patient, are you now routinely assessing their BRCA status, and how does that impact how you would sequence those? Because right now we don't know that we put them on trial to put the combination, but now we have we anticipate two approved strategies.
So you mean if you find a BRCA mutation and a PD-L1 expression,
Which,
would you go
do you
to
give a
a
tezo
PARP
or do you give
inhibitor?
exactly.
You can do a sequential treatment, of course.
How are you going to sequence it?
You will do first the immunotherapy and then the PARP
I've heard
inhibitor.
people say the opposite. I mean, I think it's an interesting question.
I actually would agree with you. I think
Yes.
for me, what we've seen from immunotherapy and some of the monotherapy data, we're still waiting for long-term follow-up from Impassion 130, is that there's probably a small subset of patients that are going to be cured of their metastatic disease with immunotherapy. PARP inhibitors, while they extend progression-free survival, I don't think is going to cure people. So for me, I'd want to give those patients the opportunity to be cured with an immunotherapy. Granted, that's a very small number, but if I can try for that, I'm going to want to try for that first.
Yeah, I think that the question is then also maybe complicated by, as Rebecca alluded to, the impact of PARP inhibition on the immune response. So in addition to the upregulation of PD-L1, it activates the STING pathway. There's any number of reasons to think that maybe giving the PARP first would. I just think
It's an induction you're talking about. I think most people want to give chemo in the
Right,
first-line metastatic setting because of the way people present. But
Right.
one very intriguing concept is whether you should be priming with
Right.
maybe the PARP inhibitor, or that whether in the future we'll be using the PARP plus immunotherapy as a maintenance approach, which I think is also really fascinating.
It's actually fun,
idea.
though, that we're actually even having this conversation
Absolutely.
because we have things that work.
It is. I think, cost aside, but I think, and complexity of toxicity, which you mentioned, which I think is going to be really important and we should mention. But I just wanted to also talk about what you said, which is you don't see PARP maybe having these long-term disease control. In the Olympiad trial, the overall survival, there wasn't any difference in overall survival as presented by Mark Robeson at AACR this year. But when he separated out the groups in small numbers into first, second line versus later, there was a big difference. I mean, the early patients seem to do much better. Maybe there's less resistance pathways. So it could be that some strategy in the early part would be helpful, and you first, maybe even neoadjuvant, adjuvant, it's hard to know. I think the toxicity of both of these agents are important. What would you say? I think there's two questions really to address as we sort of move on to the next group of agents in this approach. So what are the toxicities that we're thinking about with immunotherapy, and how are we monitoring for them? And the same true for PARP inhibitors. Are we worrying about telling people of risk of secondary cancers?
For immunotherapy, I believe we need to learn how to manage, because if you recognize early an immunocheckpoint inhibitor toxicity, you can prevent. This is a very important point, because what we observed in the Impassion 130 is just a thyroid dysfunction. Hypothyroidism in 70% of the patients, but overall, I believe it's very, very well tolerated, the immunotherapy. So the more we learn how to manage toxicity according to ASCO guidelines or ESMO guidelines, the less toxicity we will observe. Regarding PARP inhibitors is another issue. You have anemia, you have thrombocytopenia, you have leukopenia. So this may impact, I believe, compliance to treatment. You may have dose discontinuation, dose reduction, but this is related to the mechanism of action of the PARP inhibitors. What we know that there is an improvement in quality of life, so it seems that toxicity does not impact on the quality of life for our patients. It's better than chemotherapy.
And in immunotherapy, we do sometimes see very serious toxicities.
And I was building on your point, I completely agree. I think the key with immunotherapy-related adverse events is early detection and treatment. And actually at our institution, we've started an immunotherapy complication service. And that started because
Only
we
at
were...
Harvard.
I should say we have one
We
too.
have that at our institution, yes.
And the reason was exactly this. If you can detect it early, you can treat it better. And as these agents get moved to the neoadjuvant setting and the adjuvant setting, which is a curative setting, even something that is a 1% incidence, if it's a lifelong problem, be it autoimmune diabetes or the adrenal problem, as we were talking earlier, that has major implications for patients.
And so in terms of how you manage that, is that it's a patient education issue? How do you, somebody gives a patient, we expect we'll have immunotherapy approved with atezolizumab, some taxane combination next year. What are you going to do about following these people? How do we educate them? We all have the problems. I mean, capecitabine is a really good example of how patient education was critical to avoid
Explain to the
mortality.
patient the timing of appearance of the immune-related adverse events, skin toxicity, gastrointestinal toxicity, and you tell the patient, if you will have diarrhea or skin rash, please contact us and come to the hospital and we will manage, and there will be no evolution from a grade 1 to a grade 3-4. I am very optimistic, I believe, from the experience of the other disease. If you manage the toxicity earlier, you will have a better outcome. I don't believe it will be a big issue in the real life.
But I don't think it's just patient education, it's provider education as well, and not just the MD physicians. All of us rely so heavily on our entire team. And so the patient who might have a bit of abdominal pain will have very different counsel if they've received an immunotherapy agent versus not receiving an immunotherapy agent. So the whole
It's multidisciplinary.
the
Yeah,
whole team, yeah.
yes.
I mean, I couldn't run my
Yes.
practice without the mid-level support, and so it's education of the entire team.
So we've actually, we have these really exciting new agents, the immunotherapy, AKT inhibition, PARP inhibitors, but we've also seen an explosion of antibody drug conjugates, really exciting data. DT, you've been very involved in some of that area.
I think antibody drug conjugates have a different philosophy as compared to the other targeted agents. So we were talking about triple-negative breast cancer and how it is heterogeneous and it can be divided based on PAM15 to 5 molecular subtypes, or one can look at pathways. The other way to target a tumor would be to look at the receptors and then just purely use the receptors as a gate to deliver chemotherapy. And one of the agents we've been involved with is sacituzumab govitecan, which targets TROP2, which is an antigen that is expressed in more than 95% of triple-negative breast cancers. It's also expressed in ER-positive breast cancers. And the reason is that it's more like an epithelial antigen. It's EpCAM2. So it's overexpressed in most solid tumors, but in, specifically triple-negative breast cancer as well as ER-positive breast cancer. So we looked at an agent that targets TROP2. It has a linker, and the toxic payload is SN38, which is the active metabolite of irinotecan. And in preclinical models, this agent was able to deliver 136 times SN38 as compared to irinotecan alone. So you can really give high doses of toxic payload to the cancer cell. In the phase 1 basket trial, We looked at various solid tumors, including triple-negative breast cancer, and saw responses even during the dose escalation phase of the phase 1 trial. So the trial then got modified and focused just on triple-negative breast cancer in the third line and beyond setting. And the reason to do that was, if you look at the response to standard chemotherapy agents in the third line and beyond setting, it's usually in the range of 10 to 15%. The progression-free survival in that setting, it's usually 3 to 4 months. So it's clinically an unmet need. So we wanted to see if we would see activity in that setting where we really don't have a lot of agents. And in that setting, we saw a response rate of 33%. The updated data were presented at San Antonio this year, and a progression-free survival of about 6 months. So it's approximately double of what you would see with standard chemotherapy. Having said that, this was not a randomized trial. So there is a confirmatory randomized trial called the ASCENT, which is looking at this agent versus standard chemotherapy. The second point I would want to mention is that we saw responses even in patients who had received prior PD-1 therapy. So some of the patients who went on this trial were on Impassion or Keynote and had received PD-1 inhibitors, and even in that subgroup there were responses. And it could be that the use of PD-1 agents sensitizes the tumor to subsequent therapy, or it could be that this is completely cross-resistant with PD-1 inhibitor. But this has important implications, because if PD-1 inhibitors do become approved in the first-line setting, you can still use this agent after PD-1 therapy.
I know that we're looking for potential accelerated approval of the drug. We'll wait and see what our regulators say in the early part of next year as meeting an unmet need in triple-negative breast cancer, and that there's also studies that will be starting in hormone receptor-positive disease based on other data that you've presented. And there are other antibody-drug conjugates, ladiratuzumab, that is vedotin, which is targets LIV-1, also has some very intriguing data in triple-negative breast cancer. And we have HER2 ADCs that work in low HER2. We may even be identifying a whole new area of markers, but not a lot of patients with triple-negative disease. The basal-like have 1 or 2 plus HER2 disease, so we'll see where that goes. But it's certainly an exciting area. We have to balance the toxicity, but these drugs seem to be pretty well tolerated overall. As well. I think it's an exciting new approach. In developing these drugs, a lot of what we're thinking about is sequencing and how we're managing it, as well as how we get tumor tissue. And I know you've been involved in development of a number of different agents, including even vaccines, which are a big challenge. But what do you see? How are we going to face this challenge in biomarker and drug development?
Yeah, I think that, you've hit on it, and we've been discussing it for the entirety of our conversation, that we recognize now triple negative, of course, is not just one disease, and so we will need to identify biomarkers. And then the question becomes, do these biomarkers change? To Rebecca's point about it could be pathway activation as much as just the expression of a certain marker. And so I think the need will be, when we design our clinical trials, to be very thoughtful with respect to our correlative studies. And we're going to probably have to be more rigid with respect to the timing of the biopsy, with respect to initiation of therapy, as well as trying to get on treatment biopsies, which we haven't routinely done before. The question then becomes, when on treatment do you do it? Where do you biopsy? And then I actually believe there will be great utility in get on progression biopsies. So if anything, we're going to need to appeal to what I think is, a very generous spirit of the breast cancer patient to allow us to do these biopsies in order to learn. And we're at the point where we have to do that. We can't not gain that information from our studies, because it's going to be so critical to determine which agent, which combinations of agents, when to change agents. So it's a fun time, but a challenging time.
I agree with you. And the triple negative, the more we know in the early breast cancer setting, the more can be extrapolated in the metastatic. So it's completely different, because it's quite important to get tumor. Yes.
I think there's a huge effort now towards a pathway of drug development of looking at serial response in the neoadjuvant setting and getting biopsies and blood as you go along, and the I-SPY 2 Plus sort of plan of development is focused on this idea of having sort of, you give a first step and then you base your next treatment on response.
And let's not forget that part of our previous conversation, the blood. If it's possible, as we do this effort that I was just referring to of serial biopsies, if we get blood and we can somehow figure out a correlate between what we see in the blood and the tumor, and for some markers we probably will, and for others we clearly won't, but having the opportunity to develop liquid biopsies that would correlate with what we're seeing in the tumor as things move forward would obviously be beneficial for our patients. It's easier to have a blood draw than a breast biopsy.
Absolutely. And maybe we'll see better representation of the entire tumor. It's hard to know.
Yeah.
This has been a great conversation talking about triple-negative breast cancer. It's such an exciting time, and I feel like, we finally have something to talk about that actually can go into the clinic as opposed to sort of theoretically. But we also saw at San Antonio this year some other exciting information. I think, the sort of the talk of the hour is the Catherine trial. And as we sort of finish up our conversation, I just wanted to talk about the key points that we've learned over the course of this year and how they apply to our clinical practice. The Catherine trial looked at patients who had residual tumor after neoadjuvant chemotherapy with trastuzumab-based treatment. Very few patients received pertuzumab based on the timing that the trial was done, but showed really remarkable data with a significant difference favoring the patients who were randomized to receive trastuzumab emtansine versus continuing with trastuzumab to the end of the year, as we usually do. I was fascinated in the data. 70% of patients had hormone receptor positive disease, which is the highest percentage we've seen in any trial in HER2 positive disease, suggesting again that these patients maybe have less sensitive disease to HER2 targeted therapy, why they would be more sensitive to TDM1. We know that the median follow-up is still relatively short for ER-positive disease at 3 years, but a hazard ratio of 0.5 for disease-free survival and 0.6 for distant disease-free survival is really tremendous. How do you see this impacting your practice? And we'll just go quickly through everybody and see what are you going to do on Monday?
I think this is practice changing, and so if I have a patient who has residual disease after standard neoadjuvant chemotherapy, ACTHP or TCHP, I would consider TDM1. The challenge is the patients who are already on Herceptin. So if I have a patient who had residual disease and currently is on Herceptin for, say, 3 months or 6 months, should I stop that and switch to TDM1?
Rita?
No, it's certainly practice changing. A lot of my partners who weren't able to attend the meeting were emailing, asking for the details of the Catherine study, and it's certainly practice changing. And in my practice, I'll plan to switch those patients over to TDM1 for the remainder of their year of therapy.
I have to say, I got chills when I saw the data again. I think it's been a while that we've seen something so practice changing, and I think for me there's a few lessons. One, that it's a great model to look at residual disease, and a lot of our new trials, not just HER2 positive, but other subgroups, I think it's a great model. I think in terms of people who work around the world where you're trying to be cost effective with your treatments, to me this is really an important step. And I think the final thing is, in HER2 positive and other subtypes, it's cost effective to try and streamline our treatments and figuring out the right drug for the right patient at the right time. And I think if we get that right, we'll have less toxicity and it's going to be cost effective. So I'm quite excited, and I agree with you. I think 20% of the patients did receive pertuzumab neoadjuvantly. So I think it has a broader application than we anticipated.
And building on your point and speaking to my surgical colleagues, I actually think this is a trial that speaks to us. And what I mean by that is we should be referring these patients for neoadjuvant therapy. And perhaps not the T1A and 0. Those patients will do well with an upfront surgical approach and then Taxol Herceptin. But there is now convincing data that if we provide neoadjuvant therapy, that can guide subsequent therapy. So as a surgeon, I think this will certainly, we at our institution, we're already doing neoadjuvant systemic therapy for all these folks, but that's not necessarily routine across the country. And so I'd ask my surgical colleagues to really consider referring your HER2 positive patients for consultation for the consideration of neoadjuvant treatment.
Yes, in St. Gallen 2017, we gave a great endorsement to neoadjuvant treatment in HER2 positive and triple negative population. And I believe Catherine trial replicates the excellent results of the CREATE-X in the triple negative disease with capecitabine in the residual disease. So we have 2 trials confirming that additional treatment of course, may improve disease-free survival and distant disease-free survival. So it's quite important. And on Monday morning, if available, I will use TDM1.
It is interesting. I mean, such a huge practice change for us, and I think it really promotes the concept of neoadjuvant therapy for tumors that are maybe more than a centimeter. I mean, even for a 1.5 centimeter triple negative tumor, it's worthwhile to consider neoadjuvant therapy because we may be able to tailor the treatment. And this is, now we have 2 trials that show that we can do this. Really a remarkable, I think, advance in what we're thinking about. The last question before we close is, we have neratinib. We saw some data at this meeting that neratinib in certain groups of patients seems to be quite highly effective, people who started within a year of the end of adjuvant trastuzumab, and other patients who had residual disease after neoadjuvant chemotherapy. This is a oral tyrosine kinase inhibitor, very potent. It has some toxicity, although managed much better now with the data from the control trial about managing the diarrhea up front. But it works in a different mechanism of action. So are we still going to be using extended adjuvant neratinib in ER-positive disease with a very high risk of recurrence? If you look at Catherine, the patients who had positive nodes still had a very high recurrence rate. I mean, much lower with the TDM1, but the recurrence rate was over 20% in these patients, 17 to 20 and 4 or more nodes. It was quite high.
I don't have this response following TDM1, but following a standard of care, if you have an high risk and you are ER positive, I would advise for an extended neratinib. But in the context of the Catherine trial, we don't have the response.
I agree with you. I don't think we have the data for using neratinib after TDM1. So in my practice, I probably would restrict it to patients that are getting standard trastuzumab then a year afterwards.
Yeah, I would agree.
I guess if there's a young patient that you're really worried about who has lymph node positive disease, you could have the discussion of use of neratinib. But in general, because the TDM1 results look so good, we'll probably stop therapy at that time.
Yeah, I have a little different perspective in that if you look at all the data in the patients, there was a big benefit in all the subgroups, but there's still patients at 3 years, meaning in the ER-positive group, there's still going to be more. I think there was almost 20% relapses in the node-positive population, and once you get to more than 3 positive nodes, the relapse rate was quite high. So, but much lower getting TDM1 than not. But if you think about using an alternative mechanism of action, we still want to reach that ceiling of close to 100% of patients. So to me, I think it still would be worthwhile to consider an alternate agent, because what we've learned now is that by giving different drugs sequentially in these patients, we seem to be able to capture patients who otherwise would develop recurrent disease and then die of their disease. So I think it's certainly worth a consideration.
So I totally agree with you on the one hand. What I think is the issue is that I think HER2 positive disease, just like triple negative, is actually very heterogeneous. And so if you look at the Alex Pratt's molecular classification and Lisa Carey's work, you look at ER positive, HER2 positive breast cancer is very different than ER negative, HER2 positive. And I think what we as an academic community need to do is figure out who are those ER negative, HER2 positives that don't actually even need chemotherapy. And so I think what we need to now think about is how do we stratify these treatments? And like you said, maybe the ER positive ones are the ones that need continued ongoing blockade of both ER and HER2, but the ER negative, HER2 positive are more like the acute ones. Give your best drugs up front and target, if they're HER2 enriched, really sort of target HER2.
Yeah,
That's a good point, because the follow-up for the Catherine is short at this time. So it's possible that with additional follow-up, even in the TDM1 group, you might see more recurrences for the ER positive, HER2 positive group, and that's where neratinib has the most benefit.
Yeah, it's interesting. I mean, it'll be, having a wealth of riches is a good thing. And we're going to now have, this trastuzumab DSA-201, which is in a number of randomized trials looking at comparing to TDM1 in the metastatic setting in studies with this HER2 low group, which is a newly identified group, and with some new studies in combination with immunotherapy even so. A lot of advances and really exciting things. As we close up, I want to thank everybody for your tremendous comments. It's been a great conversation. It's a really exciting time, and I think maybe we'll be able to get back together again next year and see where we've gone in the last year. Thanks very much.
Thank you.
Great.